we started with the students in and you guys can help him too. He's just on the spot for the movie, right? So we started this with the stopcock in an open position, but the syringe on here, so even though this is open, no air can get through. So when he pulls up and down on the diaphragm and simulates this, air is coming in through the airway, right, and going into the lungs. But are they inflating much?
Some.
A little bit. So he's able to change the pressure. How is he able to change the intrathoracic pressure here? He's changing the volume, right? So when he pushes up on the diaphragm, what's happening to the pressure inside here? It increases, right? Because pressure and volume are inversely related. When he pulls down, what's it doing? So why do the lungs inflate? Okay, but how does moving this get negative pressure inside the balloon? Because ultimately, we got to get negative pressure in here to get the air to move in here. Well, why would they expand though? Because they have the space to expand when he's not moving the balloon, right? So you can't say it allows them. What's he doing?
It's balanced in here like this, and then when you change it, then the balloon volume changes to compensate.
Exactly. Did you guys hear that? So when the diaphragm's at rest, we have equal pressure on the inside of the balloon and outside the balloon. What does the pressure outside the balloon represent in the chest? The pleural pressure. So right now, the pleural pressure, or the intrapleural pressure, is equal. So when he pulls this down, he's decreasing the volume. He's decreasing the pressure. He's increasing the volume and decreasing the pressure. So that causes the pressure to need to equalize inside the balloon. So if we want equal pressures, how does the balloon lower its pressure inside? It increases the volume, which causes air to move in, right? That's how inhalation works. So right now, the intrapleural pressure is equal, but is that how it is in the body? Yeah, it's always less, right? So we have the students pull 20 mils of air out. That's the next part. So they pull 20 mils out and they close the stopcock. Go ahead and close it. Now what have we just done?
Decrease the pressure.
Okay, so I want you guys to notice this, what happens when I do that. Okay, it's kind of subtle, but when I do this and I put the air back in, when I do this and I open, the lungs will inflate more. These were already kind of inflated, but they get a little bit bigger. So I'm going to go ahead and take this off just because it's bulky when he's breathing. Go ahead and breathe some more. The lungs expand and contract a lot more now. They'll never get huge because we don't have enough pressure change to do this, but notice they're deflating and inflating a lot more. Why is that? Okay.
Because if you have changed from, like, say, I don't know, 756, like inside the lungs you have 756, outside you have 760 atmospheric. Like if you decrease that even more, there's more of a gradient for the air to rush in, so you get a greater expansion.
You're kind of on the right track, but do you guys hear what she said? She said she was talking about comparing atmospheric pressure to alveolar pressure. But what we've changed is intrapleural pressure, and there's a barrier between atmospheric and intrapleural pressure. So how does adding a negative intrapleural pressure make the lungs expand and contract more?
In order to equal that, or more oppose that negative pressure. I just feel like it makes sense intuitively, but it's hard to articulate.
And the students have the same problem, and that's why we're asking this question. Okay, so the way I think about the intrapleural pressure is the intrapleural pressure basically sucks the outside of the lung to the chest wall. Okay, it's not really true because you have movement, right? The nice thing about the pleura is it's nice and slippery, so it lets the lungs move and not get abraded when they hit the inside of the thoracic cavity. But you've got to have that intrapleural pressure because it helps transfer the change in volume that's happening in the thorax to the change in the lungs. It keeps the two membranes in concert. Okay, you can think about it this way. If you have more air in the pleura or more fluid in that interpleural space, the lungs can't occupy as much of the volume of the thoracic cavity. So as the thoracic cavity increases, if you've got a lot of air in there or you don't have a negative pressure, there's nothing holding the lungs to the thorax, so they'll expand with it. Does that make sense? Well, one way I think about it, and I think a model to use is, have you ever gone to Brahms and you've gotten a big straw and you've tried to suck a shake through it? What happens is when if you keep sucking, if the shake doesn't come up into it, the sides of the straws come together and it's kind of a vacuum that holds the two sides of the straw together. So if you think about the two sides of the straw being, one side being the thorax and one side being the lung, if you put a negative pressure, it's going to pull those two pieces closer together. So when one moves, it pulls the other one along. Whereas if you don't have that negative pressure, there's nothing holding them together, they don't work in concert. Now, if you get a positive pressure in the interpleural space, what happens? The lung collapses. Okay? So having a neutral to negative, you got to have, or your lung isn't going to happen, as your lung is going to collapse. Okay? But the interpleural pressure in the real human is always going to be negative, and that's super important because without that, you can't expand the lung. Right? And we actually mimic that next, right? So we open this. So now we can move air in and out. And we have them put their finger over the top of this. And the reason why, and I'll tell you guys this, so if a student asks, you can explain this. This is mimicking what? When you have a hole in the chest wall that's letting air in, what's that called? It's a pneumothorax. So we're simulating a pneumothorax. So when we breathe, we have this little airway here that air is going to move in and out of. This is actually a pretty small tube, so there's a lot of resistance in that tube. So we actually see more of the effect of a pneumothorax when we don't allow air to move in as easily through that. But see, as I'm moving this now, can you hear the sucking? Mm-hmm. What's making the sucking noise? It's moving in here. So instead of pulling, and I'm not occluding this, I'm just kind of blocking it. I'll see if it works without that. But if I just increase the resistance just a little bit, those lungs don't move much at all. Why?
Because there's another easier.
Okay, so it goes back to what the
You can't change the pressure because you're letting the air back in, so the volume is not changing.
Okay, so this leads back to what the purpose of the interpleural pressure is, right? So the interpleural pressure keeps the lung, it allows the change in pressure from the diaphragm within the intrathoracic cavity to transfer to the alveoli because it changes the volume of the alveoli. If you have this open and you're moving this up and down, the pressure change is going to happen in this space, not in the lung. Make sense? Would you like it explained in any other way? Okay, so this is a very simple model. And the temptation will be for the students to just pick it up, put it together, and go, oh, that's cool, and then just put it down. But there's really a lot of important questions to get to really see if they understand it. And this is really the only time that they can model interpleural pressure and actually see it work.